CX is proud to be supported by AMBOSS, a medical education platform with an expansive resource library and USMLE-style question bank.
Hello and welcome to 10 Clinical Minutes. I'm Brianna, and today we're going to be talking about lab collection, specifically focusing on blood collection. So to start out, I just wanted to walk through the process of what actually happens when we order labs. So it'll start off with the doctor or nurse practitioner, whoever is ordering, putting in the order. Then that order is going to go to the lab. Obviously, then the lab has to see the order. And then the lab tech or the phlebotomist is going to look at the rest of the labs that have been ordered on this patient. They're going to see if they've had any recent labs that maybe this could be added on to. And they're also going to look at the timing of other labs that the patient has scheduled for the rest of the day. If possible, they'll try and consolidate them to save the patient a couple of pokes. If there's a strange or a rare test, they might also have to look up the proper tubing and handling for that test. Once they've figured out the best time to draw the lab, they'll put it either at the beginning or the end of the draw list, depending on the urgency of the test. So if, for example, it's a routine test, it might go towards the end, but if it's an ASAP or STAT test, they might go draw it earlier than they would have otherwise. Next up, the phlebotomist has to travel to the patient, and sometimes at bigger centers or academic centers, the nurses will actually draw the labs, and so at this point, the nurse will be drawing the lab. And an important thing to note, especially if it's a phlebotomist drawing the lab, is that they will oftentimes just wait outside the patient's room if there's something else going on. So if there's an x-ray tech or a doctor in there talking to them, that'll also delay getting the lab drawn. Next up, they're going to actually perform the phlebotomy and draw the blood. Then they will send that blood down to the lab, normally through a tube system. You've probably seen these before. There sometimes can be malfunctions in the lab tube system, and sometimes they might get stuck. That has happened before many times. So sometimes it's not their fault. If things aren't coming back, it's always worth it to check into what's going on. You might be the first one to catch a problem. Next up, the lab scientist will receive the sample down in the lab and perform the testing on it. Sometimes this is done via equipment and machines. Sometimes it requires a lot of manual work. It totally depends. And as in most processes, things can go wrong. So sometimes a machine malfunctions or the test just doesn't work and they have to do it again, and that's going to restart the timer. When the scientist gets the results, they will either enter them straight into the computer, or if it's a critical result, they'll call the doctor straight away. But either way, then the doctor will get the results and can act on those results for their patient. Keep in mind that just like any process, things can go wrong at any step and delays can happen at any step. It's not always ever one person's responsibility, and there are many factors that go into how soon you get your lab results back. So next, moving on to the different options that you have to order, specifically with chemistries. I wanted to lay this out because this isn't fully explained super well at any point in a lot of our training. So to start off with, a BMP, or basic metabolic panel, sometimes called a Chem 7, is basically your fishbone diagram plus calcium. So it's your main electrolytes, including your sodium, potassium, and creatinine, and then it also adds on calcium. A CMP, comprehensive metabolic panel, otherwise called a Chem 14, is the same test as a BMP plus liver tests. So that includes your albumin, your protein, your liver enzymes, and your total bilirubin. A liver panel is just those liver tests, and it includes the direct bili. Finally, a kidney panel is a BMP with the addition of an albumin and phosphate. So depending on the hospital, sometimes some of these panels will be available versus not. Not all hospitals have isolated liver or kidney panels available to order, but if they do, sometimes it can be cheaper for your patient to do things like order a kidney panel than to order a BMP plus an albumin plus a phosphate. So something to be aware of depending on the institution where you work. Now I'm going to walk through all of these tube colors that we see all around the hospitals. Each color corresponds to an additive, and that additive dictates what test can be run on that tube. We're going to go through each of these one at a time. To start off, the blue top tube is a sodium citrate. Sodium citrate is a reversible anticoagulant that binds to calcium. And this is specifically used for coag studies. So your PT-INR, your PTT, all the clotting factors, and a lot of lupus tests. The reason for this is because that sodium citrate is reversed in the lab, so then the lab techs can specifically run these clotting tests on the blood. If you are drawing this yourself, you have to know that the tube must be filled to an exact line. There's little black arrows on the tube, and it has to be within that black arrow. There's a preset vacuum, so it'll draw a little bit slow, but it should, unless it's defective, draw right to that amount. Next up is our red and our gold tops, and sometimes you might see a tiger top tube, which is kind of a blend of these, which can be thrown in there as well, and it does the same thing. These are tubes to test the serum. So in these tubes, the blood will be allowed to clot, and then we'll be testing the serum, which is the blood plasma minus clotting factors and anything else that gets caught up in the mix of coagulation. So you can run most chemistry tests on this, and also a lot of drug monitoring and immunological testing like antibody levels would be done on a serum tube. Next up is our heparin tubes. Heparin tubes are used for testing plasma, and there should be enough heparin in each of these tubes to inhibit all of the clotting factors that are in a sample that size. Most chemistries are preferred to be done on a green top tube, although many can also be run on a red or a gold, but it's just a little bit of a cleaner sample to not have coagulation happen because that can catch up a few things in the mix of the coagulation. Important thing to note here is that a light green tube is a lithium heparin and a dark green is a sodium heparin. So if you're getting lithium levels, that cannot be added on to a general chemistry normally. And if your lithium level comes back crazy high, consider getting a redraw because it might have been accidentally drawn in a lithium heparin tube. Similarly, if your BMP or CMP has a sodium that's super high, like 170, 180, and it doesn't make sense clinically, again, have them do a redraw because it might have been accidentally drawn into a sodium heparin tube. Next up is our EDTA tubes. EDTA is an irreversible anticoagulant, and it's a preservative of blood cells. So most hematology tests can be run on EDTA tubes. So basically anything that you would need the cells to still be floating around in the blood, or anything that the clotting process would disrupt. So we're talking about things like a CBC, a SED rate, A1C levels, viral loads, and peripheral smears. A pink tube also has EDTA, so it's essentially the same tube, but pink tubes are specifically for the blood bank. This has a couple of different reasonings behind it. One is that they're typically bigger, and the blood bank needs a lot of blood to run all the different tests that they do. Also, it requires specific labeling and identifiers for the patient for the blood bank. So as a side note, if there was previously a blood bank draw, like a type in screen, and you forgot to order a CBC, go onto the lab and ask because you can usually add that on really easily to a blood bank sample because a CBC does not take very much blood. Finally, we have the gray top tubes. The gray top has sodium fluoride and sodium oxalate, and these two factors will inhibit glycolysis and prevent clotting. The purpose of this is to test things that would be heavily influenced if glycolysis were to continue to happen in the blood as it was taken from the patient down to the lab. In a lot of hospitals, this is used to test for lactic acid and for delayed glucose measurements that might take some time between the patient and the lab. It's also used for legal blood alcohol draws. Lactic acid typically needs to be put on ice to help further delay glycolysis. So big point here, especially in the emergency department. If you want a lactic acid, you need to order it with the other labs. Otherwise, it cannot be added on and the patient will have to be stuck again. Again, this is its own special tube and it needs to be put on ice. So either they won't let you add it on, which would be the correct thing to do, or if they do try and add it on, it's probably going to be inaccurate anyway, because if glycolysis was continued to allow to happen, it's probably an inaccurate lactic acid level. Depending on the lab, sometimes they can run some of the other lab tests on this tube because it is anticoagulated, but that really depends on the lab, so it doesn't ever hurt to call down and ask. So basic rule of thumb is that coagulation, blue top, chemistries, green top, hematology or cell counts, purple top. And if you're not sure, just call the lab. This rule of thumb is handy for the common situation where you're in a patient's room and the nurse is drawing labs and she says, "Hey, I got a blue and a purple top. Do you need anything else?" You're probably like, "I don't know. I know what labs I want. I don't know what tubes that go in." If you're not sure and the patient is stable, it's not a big deal to get an extra tube. You can go ahead and, quote, get a rainbow. And that typically means getting a blue, green, red or gold, and purple. That will cover almost all of the general tests that you will need on your patient, unless it's a specific or specialized test. The lab will go ahead and hold extra tubes even if you don't order a specific test on that tube. So again, if your patient is stable and it's not a big deal for them to lose the little bit of blood that goes into that extra tube, it saves them an extra stick later to go ahead and get the full rainbow. Let's say you ordered labs earlier in the day and you think of something else that you want to order. You can always look at if you can add it on. More often than not, especially in the hospital, you can add things on. Again, it depends on what you ordered earlier and what they got. But oftentimes, especially with routine morning labs, we can add a lot of things on to that blood from the morning. In addition, most hospital labs will store blood for up to 7 days in the fridge down in the lab. So if there's a test that's not super time sensitive and it would have been reasonable to add that on to yesterday's blood, you can call down and see if they can do that for you. Again, when in doubt, call the lab. If you can't add on something, check to see the next scheduled lab draw and time it if possible. We're trying to consolidate the number of times that our patients have to get stuck. Think about if you were in their situation. Do you want to get stuck with a needle 4 or 5 times a day? And if the timing isn't critical, just put in a note for the order that it's okay for the lab to retime the draw for morning labs or for whenever the next draw is. That tells the lab that it's not super time sensitive and you as the ordering physician are okay with that being retimed on their end. There are also a bunch of other tests that have very unique tube requirements. This is not by any means an exhaustive list, but just some common ones would be a TB test, like a quantiferin test or another interferon gamma assay, have very specific tubes. And the reason for this is they have to have different controls and parameters of the test to be correct. There's also yellow glass tubes, which are acid citrate dextrose tests that are used for tissue typing. And dark blue navy tubes are for heavy metals. So also keep in mind, if you want to test a heavy metal, can't be added on normally, it's its own tube. Finally, if you want to test for an ammonia level, that will typically go in a purple top, but it has to be put on ice. You cannot add on an ammonia if it was not put on ice, and it needs to be transported very quickly to the lab. Otherwise, it will be inaccurate because the cells will have continued metabolizing, and that will make your ammonia level inaccurate. Now, a word about blood cultures. Blood cultures have to be drawn first in a sequence of labs. This is because they require a very specific skin cleaning procedure prior to them being drawn. And this is for good reason. It's to make sure that the skin is sterile before the skin is poked. Otherwise, that's how you get contaminated blood cultures. Each set is a separate stick. So oftentimes the base order is that we'll order 2 sets of blood cultures. This means that the patient has to be stuck at least 2 times. And if one of those sticks isn't successful or doesn't get enough blood, then they have to be stuck a 3rd time, and so on. Ideal sensitivity for blood cultures comes from 10 milliliters per bottle. And there's 2 bottles per set, so that's 20 milliliters per set. So this has 2 implications. 1, keep in mind how much blood you're taking from your patient, especially in the ICU. If you're ordering blood cultures every day, or if they've just had a ton taken from them in the last few days because of spiking fevers or whatever else, that's a lot of blood loss. Secondly, if your patient is a hard stick, which a lot of our elderly patients are, you're not going to get as much blood, and so your cultures may not be as sensitive. These blood cultures go into an automated machine down into the lab. That machine will detect if there's something starting to grow in the culture medium in the bottles. If it goes positive, then it will be plated onto a traditional microbiology plate for identification. So this whole process takes time. And understanding where in the process your sample is can help give you a better idea of the timeline and maybe how burdensome that bacterial load is in your patient. For example, if it pops positive in less than 12 hours, that might be a pretty heavy bacterial burden in their blood, versus if it takes 2 days or any longer, it might be a much lower burden. Things like Staph aureus, for example, tend to pop positive pretty quickly. But this also explains why it takes time to get those culture values back. Not only do they have to start growing into the automated machine, then they have to be plated and grown out enough that they can be identified by microbiological tests. Now, a little bit on costs. We all know that labs cost money, but we don't always have a good gauge on why. And part of that's because there's quite a wide range of costs from hospital to hospital and system to system. But this is a really important point from an ordering provider standpoint to think about what you actually need. Now that you have a better idea of what's included in a test, think about if you really need it. For example, if you really want the hemoglobin on a patient, and that's what we're tracking day by day, do you really need the CBC with differential? Or are you okay with just a CBC or even just an H&H if you truly just need the hemoglobin and you're not worried about infection or spiking white blood cell counts? Look at that price range there. Just getting an H&H can be 25% or less of the cost of a full CBC with diff. Looking at the chemistries, do you need a full CMP? Are you actually worried about the liver enzymes? If you are, then totally get it. If not, then just order a BMP. It can be half the cost of a CMP. And think about that multiplied by a multiple day stay in the hospital. Looking at some of the micro tests, what is your pretest probability? Will this actually change your management? One of the big culprits of this is that respiratory viral panel, which can be over $1,000. Again, is that going to change your management? Sometimes it does. Sometimes that means that you might pull back antibiotics, and in that situation, it might be appropriate. But in a lot of situations, it simply isn't going to change management, and it's incredibly expensive for our patients. And looking at that Lyme disease PCR, if Lyme disease is not prevalent in your area, it doesn't make sense if your pretest probability is that low. For example, if your patient has not traveled and they maybe don't have classic signs of Lyme disease, it probably is something else. So again, this is not meant to be guiding diagnostic processes, but just meant to give you a little perspective as to the cost of the lab tests that we're providing. Lastly, I wanted to mention that in the COVID era, it was common to see what came to be known as the COVID labs ordered on a daily basis or every other day. This included tests like the ferritin and the D-dimer. In reality, it really didn't change management much. It might have given you some sort of an idea of how the patient was doing, but it didn't actually change how you were treating the patient in a lot of ways. So again, do we need to order this test every single day? I'm not saying that we may not ever order the test, but do we need it every day? Look at that cost. It could have been up to $400 per day just for that one D-dimer test. So again, think before you order. Money should never stop you from ordering something that might be beneficial for your patient or might affect management. But if there's a way for you to order a different test that would give you the same information for less money for the patient, that's a better option. Finally, just a few tips of what lab techs and phlebotomists really wish that we knew as ordering providers. First of all, just be aware of lab order timing and try and consolidate pokes for your patient. Lab techs are following safety rules, so when they call you about a critical or some other problem going on, they really are just caring about patient safety. The lab staff is often stretched really thin and is called upon by the entire hospital, including the emergency department, inpatient floors, ICUs, and even outpatient settings in a lot of hospitals. So be aware, be patient, and be empathetic for your lab colleagues. And finally, labs can be super expensive. And one way you can give your patients the best shot of getting it covered by insurance is by paying attention to those little ICD codes that you link to the order. That really does affect if they're able to get it covered by insurance. So take the extra second to make sure that you're associating the proper diagnosis codes. In summary, think before you order. A BMP versus a CMP versus a liver or a kidney profile, which is most appropriate for the situation that you have with your patient and what you actually need from those labs. Are you adding anything on? Are you able to time it with something else to save the patient a poke? If so, go the extra mile to do that for your patient. The rainbow rule of thumb: coagulation goes in blue tops, chemistry in green tops, and hematology in purple tops. Finally, the laboratory is your friend. They are amazing workhorses of our hospital that do a ton for us to make better decisions for our patients. Never hesitate to call them with any questions. They're always more than happy to help out. Always treat them with respect and always assume the best about them. They're our colleagues and they help us out more than we even realize. That's all I have for you today. If you found this helpful, please go ahead and like and subscribe. It really does help the channel. Thank you so much, and we'll see you next time on Decoding DX.